Our lecture today is about approach to wide QRS complex tachycardia. My name is Ahmed Salah. I'm lecturer of cardiology in South Carolina University. I'm glad to present this lecture today. First of all, definitions. Wide QRS complex tachycardia is a rhythm with a rate of equal or more than 100 beats per minute and QRS complex duration of more than 120 milliseconds. Ventricular tachycardia are 3 or more consecutive ventricular beats with rate of 100 beats per minute or more. Supraventricular tachycardia requiring participation of structures above bundle of His. A widened QRS complex more than 120 milliseconds occurs when ventricular activation is abnormally slow. Arrhythmia originates outside the normal conduction system, which means ventricular tachycardia. Abnormalities within the His-Purkinje system causing supraventricular tachycardia with aberrancy. Pre-excited tachycardias like supraventricular tachycardia with antegrade conduction over an accessory pathway into the ventricular myocardium. First of all, we have to know that most of wide QRS complex tachycardias, 80% are ventricular tachycardia, while 20% are supraventricular tachycardias. Causes of wide QRS complex tachycardia, as we see here in the figure A, this is ventricular tachycardia where the focus is in the ventricle, causing wide QRS complex tachycardia originating from the ventricle. Letter B, C, and D are supraventricular tachycardias of different origins. Letter B is supraventricular tachycardia with bundle branch block, while C is supraventricular tachycardia with conduction over an accessory pathway, and letter D is supraventricular tachycardia with apparent conduction over right or left bundle branches. Other causes of wide QRS complex tachycardia like hyperkalemia, acidosis, antiarrhythmic drugs like class 1A and class 1C, or ventricular pacing. We have to know that wide QRS complex tachycardia is a unique clinical challenge because diagnosing the arrhythmia is difficult, diagnostic algorithms are complex and imperfect, urgent therapy is often required, patient may be unstable at the onset of the arrhythmia or deteriorate rapidly at any time. Risks associated with giving therapy for an SVT to a patient who actually has ventricular tachycardia. Supraventricular tachycardia versus VT, we have to search for the clinical history as patients with old age are with ventricular tachycardia. Patients who have underlying heart disease like previous myocardial infarction, 90% of them are ventricular tachycardia. Patients who have pacemakers or ICD, these devices increase the risk of ventricular tachyarrhythmia. Medications like digoxin or antiarrhythmic drugs which prolong the QT interval can cause ventricular tachycardia. So clinical history is very important. Now we are going to discuss some terminology like AV dissociation, concordance, fusion beats, and capture beats. AV dissociation is characterized by atrial activity that is independent on ventricular activity. Atrial rate lower than ventricular rate diagnostic of ventricular tachycardia. Atrial rate that is faster than ventricular rate is diagnostic for supraventricular tachycardias. As we see in this ECG, the first two beats are sinus beats. We can find P wave QRS-T. Then wide QRS complex tachycardia starts. We can find two P waves. These two P waves, in between, we have two ventricular complex. This AV dissociation, where ventricular rate is faster than the atrial rate, this is diagnostic of ventricular tachycardia. Concordance. Concordance is present when the QRS complexes in all 6 precordial leads, V1 through V6, are monophasic with the same polarity, either entirely positive with tall monophasic R waves or entirely negative with deep monophasic QRS complexes. If any of the 6 leads had a biphasic QRS complex, QR or RS complex, concordance is not present. Negative concordance is strongly suggestive of ventricular tachycardia. Exception, supraventricular tachycardia with left bundle branch aberrancy may demonstrate negative concordance. Positive concordance also indicates ventricular tachycardia. Exception, antidormic atrioventricular reentry tachycardia with a left posterior accessory pathway. As we see in this ECG, this is a negative concordance ECG. All of the 6 precordial leads shows negative concordance. And in the figure, negative concordance means that the electrical activation of the heart is going away from the 6 precordial leads. As we found in this foci, in the anterior wall of the left ventricle, all of the electrical activation of the heart is going away from the 6 precordial leads. Positive concordance is the 6 precordial leads have positive, all are positive, and this means that the electrical current is going towards the 6 precordial leads. As we see in the figure, the focus is present in the posterior wall of the left ventricle, and according to the depolarization of this ventricle, the electrical current is going towards the 6 precordial leads, causing positive concordance. In this figure, we have 3 figures. Figure A, where is the electrical current coming from the SE node and passing through the AV node, normally depolarizing the ventricle through the Hesper-Penge system, causing a sinus beat, capture beat. Figure B, this is a ventricular depolarization. The focus is present in the ventricle, and as we see, it causing wide QRS complex due to ventricular depolarization through the myocardium, ventricular myocardium. In figure C, this is a fusion beat. Fusion beat means the meeting of the depolarization coming from the atria fused with the ventricular depolarization coming from the ventricular focus, and according to the place of the fusion, the QRS complex morphology will be, if it is near to the atria, the fusion near to the atria, so the complex will be wide. If the complex fusion is away from the atria, very far in the apex, for example, will be like the sinus beat. Fusion beats produced by fusion of 2 ventricular activation wavefronts, characterized by QRS complex morphology intermediate between normal and fully abnormal beat. Fusion beats during a wide QRS complex tachycardia are diagnostic of AV dissociation and therefore of ventricular tachycardia, but it has a low sensitivity, 5 to 20%. And as we see here, in the first few beats, we have a wide QRS complex tachycardia, and we have the 2 beats of sinus morphology, capture beat, and a beat of fusion, 2 beats of fusion. One like the ventricular activation, and the other one looks like the supraventricular activation. Capture beats or Dressler beats are QRS complex during a wide QRS complex tachycardia that are identical to the sinus QRS complex. Implies that the normal conduction system has momentarily captured control of ventricular activation from the VT focus. Fusion beats and capture beats are more commonly seen when the tachycardia rate is lower. This is an example of a fusion and capture beat. The first few beats are wide QRS complex tachycardia, and the last beats are also wide QRS complex tachycardia. And we have one with the star is the fusion beat. The ventricles are activated by 2 different wavefronts, resulting in abnormal appearance, hybrid form of the QRS complex. While the other one is the capture beat, atrial impulses that activate the ventricles. The term is used when this interrupts an independent ventricular rhythm. In this ECG, we have a wide QRS complex tachycardia. As we see, we have a single narrow complex beat, which is a capture beat, diagnostic of ventricular tachycardia. We have different algorithms for diagnosis of wide QRS complex tachycardia, like Brugada algorithm. Brugada algorithm to diagnose if this ECG is supraventricular tachycardia versus ventricular tachycardia. Brugada algorithms have 4 steps. The first step, if we have RS pattern or no. If we don't have RS pattern, so this means concordance, like positive concordance or negative concordance. Positive concordance or negative concordance is in the favor of ventricular tachycardia, while the presence of RS pattern, so this means we have all the debate between supraventricular and the ventricular tachycardia. So presence of RS pattern, still we have the debate. Step 2, the start of the QRS complex tells the nadir of the S wave if it is more than 100 milliseconds, so this is in the favor of ventricular tachycardia. If it is less, so we still have the debate if it is supraventricular tachycardia or not. Step 3 is the presence of dissociation. If we have the evidence of complete AV dissociation, this is with ventricular tachycardia. If we don't have the evidence, so we still have the debate between supraventricular tachycardia and ventricular tachycardia. Step 4 is the morphology of the QRS complex. If we have left bundle branch block morphology, we go to see the V1 and V6. In V1, if we have small R wave and fast downslope of S wave, this is in the favor of supraventricular tachycardia. While in V1, if we have R wave more than 30 milliseconds and notching of the S wave, the start of the QRS complex till the nadir S of the QRS complex is more than 70 milliseconds. This is in the favor of ventricular tachycardia. Again, in V6, if we have no Q wave, this is in the favor of supraventricular tachycardia, and if we have Q wave in V6, this is in the favor of ventricular tachycardia. In right bundle branch block morphology, in V1, if we have a small r, S r dash, a rapid figure with a small r in the first and large r at the end, this is in the favor of supraventricular tachycardia. But if we have a monophasic R wave in V1 or QR complex or RS complex, this is in the favor of ventricular tachycardia. In V6, if the R over S ratio is more than 1, this is in the favor of supraventricular tachycardia. R over S ratio less than 1, or we have a QS complex, so we are in the favor of ventricular tachycardia. In this ECG, we have a large R wave with RSR pattern in V1. This is in the favor of ventricular tachycardia, while on the right side, we have a small R SR pattern in V1. This is in the favor of supraventricular tachycardia. Other sign which is important for diagnosing ventricular tachycardia is Josephson's sign. Josephson's sign is notching near the nadir of the S wave, as we see here in this figure, and it suggests ventricular tachycardia. We have ultrasample Brugada criteria, which is presented in 2010, depending on lead 2 in ECG. The R wave peak time in lead 2, which is the duration of the onset of the QRS to the first change in polarity, either nadir Q or peak R in lead 2. If we have the R wave peak time equal or more than 50 milliseconds, the likelihood of ventricular tachycardia very high, positive likelihood ratio 34.8. As we see in this figure, the R wave peak time is more than or equal 50 milliseconds, suggestive of ventricular tachycardia. Other algorithms like Verike algorithm for diagnosing ventricular tachycardia depends on, first, if we have AV dissociation, so this is ventricular tachycardia. Initial R wave in EVR present, suggesting ventricular tachycardia. If no, so QRS complex, unlike bundle branch block or fascicular block, so this is ventricular tachycardia. If no, V initial over V terminal, if less than 1, this is ventricular tachycardia, and if no, supraventricular tachycardia is the cause. As we see in this figure, the definition of V initial over V terminal, the change in polarity in the first 40 milliseconds in ratio to the change in polarity in the last 40 milliseconds, if less than 1, so this is in the favor of ventricular tachycardia. EVR algorithms criteria looks only at the EVR. If the answer is yes, then it is VT. Is there any initial R wave? If yes, so this is VT. Is there a R or Q wave more than 40 milliseconds? This is with ventricular tachycardia. Is there a notch on the descending limb of a negative QRS complex? If yes, so this is ventricular tachycardia. Measure the voltage change in the first 40 millisecond and the last 40 millisecond. If the ratio is less than 1, this is in the favor of ventricular tachycardia. In this figure, this is a supraventricular tachycardia. The AVR morphology, the QRS complex in the AVR lead, the morphology of AVR, as we see in the right bundle branch block, the septum is normally depolarized from the left to right side, and the left ventricle is normally depolarized. So we have a first deep Q wave in the AVR lead. In the right side, we have a left bundle branch block morphology. The septum is depolarized from the right to left side, and the right ventricle is depolarized normally, while the left ventricle is slowly depolarized due to the left bundle. We have a deep QS morphology in AVR. While in this figure, the ventricle is depolarized from a focus in the ventricle. It may be apical, like in the superior figure. It may be basolateral, and this causes a positive R wave in AVR, and this is in the favor in diagnosing ventricular tachycardia. In the right side ventricular tachycardia, as we see in the left figure, the focus coming from the right ventricle causing a deep S in AVR, while in the basal septal VT causing a deep QS pattern in AVR, as this is in the favor of ventricular tachycardia. In managing wide QRS complex tachycardia, we have some questions. The first question is, this patient is hemodynamically stable or not? To diagnose hemodynamic instability, we should ask about blood pressure, mental status, if we have signs of shock or not, if we have ischemic chest discomfort or not, chest pain or not, or we have heart failure, acute heart failure, dyspnea and orthopnea or not. If one of those things are present, so we have to give synchronized cardioversion for this patient. Consider sedation, may use adenosine for regular narrow-complex tachyarrhythmia, in only narrow-complex tachyarrhythmia. If we have hemodynamic instability, so synchronized cardioversion. If the patient is stable, we don't have any of these things like hypotension, altered mental status, signs of shock, ischemic chest discomfort, or acute heart failure. If we don't have any of these, so we can use medications at that time. First of all, we can use lidocaine, consider 1 to 0.15 milligram per kilogram rapid infusion, while preparing for prokinamide, if available, prokinamide infusion 20 to 50 milligram per minute with maximum dose of 17 milligram per kilogram. If we don't have prokinamide, so we shift for amiodarone, loading 150 milligram IV, load over 10 minutes, followed by infusion of 1 milligram per minute for 6 hours. For managing VT, we should ask for the etiology of VT. Ventricular tachycardia may happen on a structurally normal heart or a structurally abnormal heart. If we have structurally normal heart, it may be idiopathic ventricular tachycardia, like outflow tract ventricular tachycardia, fascicular tachycardias, or papillary muscle ventricular tachycardia. Others, like primary arrhythmic syndromes, like Brugada syndrome, long QT syndrome, short QT syndrome, or catecholaminergic polymorphic ventricular tachycardia. In managing VT, we should ask about the etiology, because some VTs we should put an ICD, some VTs we can go through antiarrhythmic drugs, some VTs we can go through beta blockers. For example, Brugada syndrome can be managed by putting an ICD. Long QT syndrome and catecholaminergic polymorphic ventricular tachycardia can be treated by only beta blockers. Again, when we have ventricular tachycardia, we should ask ourselves whether the heart is structurally normal or abnormal. The presence of underlying structural heart disease can be caused by ischemic cardiomyopathy or non-ischemic cardiomyopathy. Non-ischemic cardiomyopathy may be like idiopathic dilated cardiomyopathy, arrhythmogenic right ventricular cardiomyopathy, hypertrophic cardiomyopathy, cardiac sarcoidosis, and Chagas disease. For managing ventricular tachycardia, we have different options of treatment, like number one, antiarrhythmic drugs. This is a first-line management of VT or VT stall. It is inexpensive, rapid effect, decrease the frequency of ICD shocks. But disadvantages, it is some contraindications and side effects of each antiarrhythmic drugs, lifelong drug therapy. While implantable cardioverter defibrillators can be used in secondary prevention from VT or VT, primary prevention with ischemic and non-ischemic cardiomyopathy, it has a mortality benefit, but it doesn't prevent VT, it increased mortality risk with shocks, and again, device infections, procedural complication. Other option for managing VT is catheter ablation. Catheter ablation can be used in patients with VT storms or recurrent or idiopathic VT when antiarrhythmic drugs or ICD is ineffective. Its advantages is reduced VT burden and the frequency of ICD shocks, decrease the need of antiarrhythmic drugs, while the disadvantages is it is an invasive procedure, sometimes has procedural complication, potential need for repeated procedures. Last, we have sympathetic denervation for refractory ventricular tachycardia when all the above management can be or is ineffective for treating ventricular tachycardia. It reduces ventricular tachycardia burden and frequency of ICD shocks, but it is of limited evidence, invasive procedure, and it has its own procedural complications. And thank you very much.